Benvenuti
Eccoci.
al primo ENDOPILS dell'Accademia Italiana Endodontics, anzi il secondo, ma il primo che organizziamo noi, giusto?
Eh sì, perché il primo l'avevo fatto io per la società portoghese di endodonzia e avevamo aperto l'Endopill anche a tutti i membri dell'AIE. Quindi grazie Fabio per aver organizzato tutto dal punto di vista tecnico questa serata.
Un
Intanto che
piacere.
aspettiamo che la gente piano piano si colleghi, intanto ringraziamo già Sebastian che è qui già con noi e tra pochi minuti gli daremo la parola, ma insomma grazie Seb, tu capisci un po' l'italiano, quindi poi ti introduco con calma. Ancora un grazie a Fabio per tutta l'organizzazione da un punto di vista tecnico. Volevo presentarvi all'inizio per guadagnare qualche minuto e in attesa che tutti possano entrare e collegarsi. Volevo presentarvi le slide che riguardano l'attività dell'AIE di quest'anno e del prossimo, partendo ovviamente da un ringraziamento ai nostri main sponsor, che sono quelli che poi ci permettono di fare con serenità tutte queste attività splendide che facciamo in grande quantità. Gli altri appuntamenti con gli ENDOPILLS International saranno il 20 ottobre col presidente della società portoghese Sergio Quaresma su ritrattamenti non chirurgici e il 17 novembre con Alexis Gaudin, presidente della società francese, sul trattamenti della polpa vitale. Quindi altri due appuntamenti da segnare sul vostro calendario e da cerchiare con il circoletto rosso. Inoltre continuiamo a fare gli study club, le serate di aggiornamento AIE, sempre su questo argomento molto caldo della terapia della polpa vitale. Ci sono tante date ancora a disposizione in tutta Italia, quindi potete cercarle sul nostro sito e c'è il calendario completo con tutti gli appuntamenti a cui potete iscrivervi direttamente dal nostro sito. Il nostro prossimo appuntamento e ultimo appuntamento dell'anno sarà il Cadaver Lab di chirurgia endodontica, quindi chi è qui oggi a sentir parlare Seb di chirurgia sicuramente potrebbe essere interessato a questo tipo di corso, un corso unico nel suo genere, con la possibilità di fare tanti interventi chirurgici su preparati anatomici umani dal 27 al 29 novembre. Ci sono ancora 2 posti disponibili, abbiamo anche 37 crediti ECM quest'anno che per chiudere il triennio nel 2025 comunque possono far comodo, quindi per tutti voi che siete qui, che siete sicuramente interessati alla chirurgia endodontica, ecco, questo è un corso unico, pratico, che consiglierei a tutti veramente di non perdere. Come ben sapete, il topic del prossimo congresso sarà minima invasività, mito o realtà, un altro congresso internazionale, sempre a Bologna, sempre all'Hotel Regency, sempre l'ultimo weekend di febbraio, come ormai di consuetudine per la nostra accademia. Avremo degli speaker eccezionali provenienti da tutto il mondo e con veramente un'attività a 360 gradi, quindi cominciate a iscrivervi. Il 15 ottobre apriranno le iscrizioni al congresso, le iscrizioni all'Accademia 2026 con l'Early Bird sono già aperte, quindi partecipate numerosi. Il Vivendo 2026 confermatissimo nella sua nuova formula, quindi per cambiare marcia alla vostra endodonzia, se volete un corso formato da 3 incontri, 2 moduli, uno base e uno avanzato, da aprile a giugno 2026 questo è il corso che fa per tutti voi. L'anno prossimo di nuovo cicli di webinar approfondendo, cicli di webinar internazionali come questi e il nostro corso di aggiornamento che sarà a Catania per un cambio della guardia tra me e il presidente eletto Eugenio Pedulla. Quindi queste sono tutte le attività che andremo a fare da qui all'anno prossimo nella mia presidenza. Se avete interesse, andate sul sito dell'Accademia, potete scansionare questo QR code e andare direttamente sul sito dell'Accademia per andare a vedere tutti gli eventi a disposizione, tutte le nostre attività. Non mancate, non perdete da questo punto di vista tutto quello che noi facciamo. Fabio, ti lascio la parola giusto per dei dettagli tecnici su questo streaming.
Esatto, semplicemente per dire che abbiamo deciso con Sebastian che le domande saranno fatte alla fine, quindi alla fine della sua relazione ci sarà un momento dedicato per le domande. Quello che chiediamo è che potete già scrivere le domande nei commenti del video, scusate, nei commenti del video, e poi dopo noi le risottoponiamo a Sebastian per ricevere le risposte. Per cui mano a mano che Sebastian spiega, voi potete tranquillamente scrivere nei commenti e poi noi alla fine della relazione andiamo a riprendere le domande che avete fatto e faremo un pochino di dibattito rispetto a quello che sono le vostre impressioni e la condivisione, insomma, delle tecniche diverse che potete conoscere oggi.
Sì,
Tutto
se
qua.
possibile fate le domande direttamente in inglese, così anche Sebastian le può vedere direttamente, ma altrimenti le traduciamo noi, perché non avremo la possibilità di aprire i microfoni al termine della relazione, quindi vi invitiamo a comunicare attraverso i vostri commenti. Detto questo, vi introduco il nostro relatore, Sebastian Ortolani, è il presidente del congresso AEDE della società spagnola, una nostra società partner, che vedete nel suo sfondo, di cui poi adesso lui vi parlerà anche nel dettaglio. Il presidente della EDE è l'amico José Aranguren, che sarà ospite al nostro prossimo congresso internazionale, quindi la nostra partnership con la società spagnola va veramente a gonfie vele, di questo ve ne siamo grati. Sebastian si è laureato nel 2000 all'Università Europea di Madrid e ha preso il suo PhD a Valencia nel 2016, professore a UCAM e ovviamente full member della EDE, della Accademia Spagnola di Endodonzia, ma anche certified member della European Society of Endodontology, e alla sua pratica privata in Alicante, ma soprattutto, mi preme dirlo, è un caro amico, e da caro amico qual è ha accettato questo invito a partecipare a questo webinar, pur essendo arrivato questa mattina dal Perù con un volo transoceanico, dopo aver partecipato a un evento molto importante in Perù, tra l'altro col nostro past president Nick Grande. Quindi doppiamente grazie, Seb. Thank you so much for being here and for your kindness and for dedicating this time to the Italian Academy of Endodontics. The event is also open to the Spanish Society members, so I give you the stage and thank you so much again. We will see you back at the end for the questions.
Grazie Gianluca, molte grazie all'Accademia. Per me è un piacere essere qui, come ha detto è arrivato questa mattina. Per me il mio cognome è italiano, ma io non parlo italiano sufficiente per fare la presentazione. Per me questo è un problema, ma andiamo a fare la presentazione in inglese.
Assolutamente.
La prossima io voglio fare in italiano. So thank you very much for the invitation, and as you say, today it's a good day for present our meeting and for make the lecture about the surgical treatments. Okay, so if you want,
you can share the screen if you want.
I can share my screen. That. Are you able to see the screen now?
Yes.
Yes.
Perfect. So perfect.
The stage is yours, Sebastian. We go on the backstage, and anything you need, we can be in touch also through WhatsApp. Hopefully there will not be any technical issue, but the stage is yours.
Perfect. Thank you very much for the invitation. As I told you, for me it's a real pleasure. I've been with a lot of relationship with the academia for a long time. When I was in the University of Valencia, almost of you that are in the academia, you know that the university has a very long relationship. And as Gianluca says, he's a very good friend. Nick says it's a very good friend. So I have a lot of really good friends, and I love Italy, and I for me it's a real pleasure to be here. So the idea today is explaining a little about microsurgery. It's when we think that the microsurgery could be an option, and the topic of this year is the microendodontics, or the minimum invasive endodontics, and we can analyze that nowadays we know that the surgery could be really, really minimum invasive. Not, of course, speaking about the bone or speaking about the gum, it's mostly speaking about which is the structure of the tooth that we are going to touch when we do the surgical treatments. Okay, so as Gianluca says, I'm Sebastian Ortolani. I'm from Alicante. Well, I really was born in Argentina, but I'm living mostly of my life in Alicante. Alicante is in the southeast of Spain. It's a very tourist city, so everyone is invited to be here. I'm teacher. I am the head of the endodontic department in the University in Murcia. I was working in the University in Malaysia for 12 years. Now I'm been in Murcia for the last 6 years. We try to do some research. We do a lot of courses. Yesterday we arrived from Peru, but 2 weeks ago we were making 3 or 4 courses in Spain too. So this is something that makes us very proud about what we do. But really, I'm a clinician, so I spend 80% of my professional activity in my clinical practice. So the idea today is trying to transmit this clinical practice and trying to explain what we do in the clinical practice and what we do in the surgical procedures. I have to say that I'm also in the dark side of our profession. I do not only endo, I do endo and implants, so I can look from the other side sometimes, and I could think that the surgical procedures has some advantage that we will try to explain. As Gianluca says also, I will be the president of the national meeting. This national meeting will be the 30, 31 of October and the 1 of November, so it will be in 3 weeks from now. It will be in our city, in Alicante. We will have more than 30 speakers. I think that the speakers we can get a really good balance between the clinical and the scientific part. All the lectures will be translated to both languages, to English. So the lectures that will be in English will be translated to Spanish, but the Spanish speakers will be translated to English, so everyone will be able to understand the lectures. And of course, everyone from the academia, that is a society that we have been with a very, very deep relationship for a long time, are invited. So if you want to come to Alicante, it will be a real pleasure to have you here. Okay. Speaking about endodontic microsurgery, or speaking about surgery, it's one of the most interesting things. It's one of the fields that make us, the endodontics, slightly better than the other ones, than the other endodontists, or we could say that we have more options to solve some cases that in the regular ways we are not able to solve. Okay, but all the specialties that have union between different fields always have problems and always have to. It's like a part of our work that some of the endodontists don't feel very comfortable. My wife is pediatric dentistry, and I always put the same example when we speak about pediatric dentistry, when we speak about endodontic procedures in pediatric dentistry or in the temporary teeth. We always think that we have to do it because we can control the procedure. We know how are the canals, we know how to shape it, we know how to clean it, we know how the irrigation is, but we don't know anything about the behavior, the control of the behaviors of the kid. So we have 2 different fields, and who has to do it? The specialist that gets information, that study, that make courses with the other specialty. So here it's exactly the same. Nowadays, it's not enough to be endodontist if we do not control the periodontal and the oral surgical procedures. We are not able to do the root canal, the apical surgical treatments. Okay, the microsurgical retreatment, we can say. Okay, why? Because it's not enough to cut the root. Of course, this was the old way of thinking of the oral surgeons, but we also have to prepare the canals, we have to seal the canals, but we have to manage the hard tissues and we have to manage the soft tissues. Of course, it's not necessary to be a periodontist or it's not necessary to be an oral surgical, but we need to know some information about that. And this is extremely, extremely important. If you are going to do some surgical treatments, we have to know, we know the endodontic procedure, and I think the most difficult part to learn and the most important part that we have in the three specialty are the endodontic concepts, are the endodontic field. So we need, I think that we are the specialists that are the indicated for the treatment, okay? But we have to know a lot of information about how to manage the soft tissue and how to manage the hard tissue. With hard tissue, we need to know if we have to regenerate, we don't have to regenerate, which is the way that we're going to regenerate, and in the periodontics, where and how we have to manage the soft tissue. Because nowadays, not enough to have a success or a survival of the tooth if we cannot get to the right aesthetics and functional situation after our treatments, okay? So we know that the goals of our endodontic treatments are the preservation or the prevention of the apical periodontitis. We will have pathosis in the pulp. This pathosis in the pulp will end in an apical periodontitis, so we have to make any treatments. So that means we are not going to do only root canal treatments, pulp, any pulp, any treatment of the pulp will be part of our treatment. So nowadays we know that the vital pulp therapy is changing a lot with the new materials. So if we make a direct pulp capping, if you make a partial pulp capping, if we make a pulpotomy, a partial pulpectomy, we are doing this prevention of the apical periodontitis. That is really our pathology. We are not, our pathology is not really the pulp pathology, is more the apical pathology. And if we have this apical periodontitis, we have to do the treatment that leads to us to make that this apical periodontitis disappear. So if we do a retreatment, we are doing also a treatment of the apical periodontitis. But if we do a apical surgical treatments, we are doing also an endodontic treatment, and we are getting this pathology that is our pathology. It's not the pathology of the surgicals. The pathology of the surgicals goes in the other way. We will be able to have a success in our treatment. Nowadays, we have a very, very clear concepts about that. The success of our treatment is absolutely in relationship with the control of the infection. If we can control the infection, if we have an infection control, we will be able to have a success. If we are not able to control the infection, the apical pathosis will stay in the tooth, so we will say that we are gonna have a failure and we are not going to have a success of this tooth. Nowadays, this infection control is absolutely related to this the disinfection of the bacteria, of the microorganisms that we have inside the tooth, and we have a chemomechanical preparation of the roots. This chemomechanical preparation has to be, of course, making by the orthograde way, or if we think in the apical surgical treatments, it could be by the retrograde way. But again, the objective of all our endodontic treatments is the disinfection, the control infection of the canals. So we have to think exactly in the same way. I'm not going to start to explain that we do that when we explain with the surgicals, that we are not going to explain that we have to clean the canals, that we have to disinfect the canal, that we have to this. And if we are not able to do by the orthograde way, we can do it in the retrograde way. But the concept is absolutely the same. It's not only to cut 2 or 3 millimeters of the canal and after making anything. Okay, but one of the most important things, because today I will explain a little which are the cases that we think that are indicated for these kinds of treatments. Usually, if we read the classic literature, we analyze that if the defect is bigger than X, whatever, 2 millimeters, 3 millimeters, 4 millimeters, the lesion will not heal properly, and it's very probably that we have to do an apical surgical treatments. Unlike if, for example, in this case, when the lesion affects one of the cortical plates, and mostly if it's the palatal cortical plate, usually the literature states that it's very, very probably that we have to propose to the patient that directly after the treatment, or in some cases, 6 months after the treatment, we have to reevaluate it. And if the lesion is not okay, we have to do the apical surgical treatments. But nowadays, this concept is not exactly right. Why? Because if we are able, in this case, we can see this case was referred to us because the patient, the treatment that the dentist proposed, the surgical proposed, was extracting of the lateral tooth, extracting of the central incisor, make a regeneration, put 2 implants, and make this resolution of the case. And as I explained to you, I do implants, and if anyone do implants will know that if we have these kinds of lesions and you do the extraction of the tooth, the situation is really, really bad. The patient will spend a lot of time, will spend a lot of money, and will spend a lot of hours in the clinic because we have to do 1, 2, 3 bone regeneration. We have to 1, 2, 3 soft tissue graftings, and after that, the success of that implant will be really, really low if we are not going to have a very, very good result. Okay. In this other case, it's more or less the same. The patient was referred in that case. The proposal that we have is to take out the central incisor, to take out the lateral, the other central incisor and the lateral incision, because the lesion not only affect to the palatal wall, it affect to the palatal bone, it affect to the buccal bone, and affect to the a bone that we have in separation with the nose. So the problem was that if you read the classic literature, so if you have a through and through lesion, and here we have two different through and through, it's buccal to lingual and also connected with the nose. This lesion will not heal properly, and it doesn't depend on the endodontic treatment. So nowadays we can say that it's not like that. If we only do the right disinfection of the canal, if we can take out all of the bacteria from the canal, we will be able to have a really good success. We will be able to have a very good healing. We will create bone. We are the only specialty that without making any kind of soft hard tissue grafting, we can create a lot of amount of bones, and we can see that we can have again the cortical plate, the palatal plate, and we can generate the separation that we have between the bone and the nose. Okay, so nowadays we will say that the size of the lesion is not is a clear indication. We have to evaluate, and if we, as I said before, is you go to the classic literature, they say after 6 months or after 8 months or after 1 year, you have to evaluate. So nowadays the idea is changing in that way. So this is a case, for example, that we. Well, sorry, I take almost all the cases out. I will not explain. It was a case that we had a recovery of the bone after 2 years. In this period, when you analyze, you could see the lesion. Okay, and nowadays the American Association of Endodontics says that if you don't have any kind of pathology, of course, and this is the most important part, no sinus tract, no movement, no percussion, no palpation, no any kind of any symptoms, the lesion is not necessary to be touched in the first 2 years. The statement of the European Society of Endodontics or Endodontology, they are not from endodontics, they are from endodontology, they say that we are able to wait until 4 years looking the healing, and we could still have some small lesion, and this is lesion we can think that it could heal. It could have a solution of the case during this period of time. So we extend a lot. We are not able to have a recovery of the bone of 2 centimeters in 1 year. It's absolutely impossible. Okay. So when we speak about the percentage of success, we have a really good percentage of success in primary treatments. If we look for the classic literature and if we see the randomized clinical trials, if we do a primary treatment, we are more or less in the 81%. If we do non-surgical retreatments, we are in the 75%. But when we analyze the periradicular surgery or the apical surgery, we have a 78%. So it's bigger than the retreatments. and it's a really, really good rate of success. Of course, the idea is this treatment is not, it's a complementary treatment when we speak about primary treatments and when we speak about retreatments or reviews of treatment, like they like to say in the AAE. The review of the treatment has to be the regular, the orthograde review of the treatment has to be before the surgical treatments in most of the cases, but we will present some of the indication that even we always say that it's a line that treatment, retreatment, and surgery. We could say that we can jump from the regular treatment to a surgical treatment, and even in some cases, we will see that it's not necessary to do the treatment, and we can do, and we will have a better rate of success if we do the surgical treatment directly. Okay, another thing that we can think about when we see that the lesion is very big is trying to reduce the pressure, tries to decompress the lesions. In that case, this patient was referred to us in 2017. It has a lateral lesion. This lateral lesion was not very big. The test was not very clear. The vital test was not very clear. The patient did not have a lot of interest in trying to make any kinds of treatments. He decides, okay, I will wait. We will see how it's happening in the future. I am not sure if you do not certify that the treatment will be perfect and you only have to treat one teeth. We explain to the patient different reasons, and he said, okay, I will wait. And he came back again after 3 years because he started to have a reduction in the sensibility of the lips, of course, because this lesion is making a pressure in the mandibular nerve. So here the situation is absolutely different. We can see that how the lesion has moved the teeth, has moved the roots of the teeth, okay, and we don't have the cortical superior part of the mandibular nerve. So it's not a case that is indicated for apical surgery. So the things that we do in that kinds of cases is make a decompression. Of course, explain to the patient that it was very, very probably that after the decompression and after the root canal treatment, we had to finish the treatment with apical surgery, in mostly hoping that the lesion is reduced, that we had this cortical protecting the mandibular nerve, and after we can clean all this lesion. Okay, but after making the decompression, we will be able to see that after 1 year, the lesion is mostly healed. It was not necessary to do anything with the decompression and with the root canal treatment, with the regular root canal treatment. Again, we can solve the situation. We can produce a lot of bone. Now we can see also that the center of the big lesion still having some small lesion. That means that the bacteria were exactly there, and it's very, very probably that it's a lateral canal there. The lateral canal was, the amount of bacteria that we have in this lateral canal was reduced, but it's absolutely sure that it's not zero. It's very, very difficult to have zero bacteria inside the canal, and we can see that the bacteria still having this small lesion, but of course we have regenerated a lot of part of the bone. So in so many cases that the lesion is very big, and we are not sure that if we can do the apical surgery, we can think in the decompression before making the surgical treatment. So again, one of the ideas is the size of the lesion is not mandatory for make the apical surgical treatments. Okay. So if we speak about the general terms, non-surgical retreatment is the first option that we have to think about when we speak about the review of a case. We have a treatment that has already been done by the primary treatment. You have to think what you're going to do. So the first idea is making the non-surgical treatments, the orthograde retreatments. But we will see that in some cases that is not possible and the retreatment fails or the condition has changed. We can think in the treatment. In which kinds of cases we have like indication? When we have anatomical variations, when we have accidents or operative accidents for prosthodontics reasons, when we have this kind of excuse that we can have in most of the cases, that is an extra-radicular biofilm, or when the treatments, apical surgical treatment has been doing before. It's really, really difficult to try to solve it by the orthograde way. And mostly if the apical surgical treatment were making in the classic way, no retroturation, no retropreparation, no retrofillings, and no the good management of the soft tissue. Okay. So we're going to analyze one by one these cases, and we see exactly, or in some cases.
Sebastian, did you turn off the microphone? Sebastian, your microphone doesn't work. Okay,
No.
perfect.
Again, sorry, I don't know what I did. Okay. For the rest, it's okay. The view is okay.
Everything is okay.
Hola.
You can go on.
Perfecto. So it's absolutely clear. We do combine computed tomography and a scan in mostly of the retreatment cases, and nowadays maybe mostly of the treatment cases when we see that we have any kind of alteration. And if we see the literature, we have the support about that. So this is a study. There is a study that is from Mohamed Fayyad and Bradford Johnson from the University of Chicago. I think that it's slightly tricky, so they do not put it very clear, because for me 62% is too much, but they show you an X-ray, like in this case. This patient was referred to us to make a root canal treatment in a central incisor. Of course, everyone that sends to you a root canal treatment or central incisor, when you're a specialist, you has to be a little worried about it, because I think that every dentist has to know how to make a treatment of a central incisor. Of course, this is a retreatment. So if you see the regular X-ray, you will see, okay, we have to do it in the orthogenic way. We will not have a lot of problems. We have to reach the apex. We have to clean the canal, and it will be a success for sure. But it's not really like that when we see the cone beam. So in that study, they showed that the people changed the idea of the treatment in the 62% of the cases. I think that it's the percentage is not as high as is in this study, but it's true that in so many cases when we see the real situation, not the 2D, the 3-dimensional situation, we are able to change, or at least to explain to the patient that we could need a secondary treatment after the regular retreatment. In this case, we said this laceration of the apical part. The patient has a trauma when the tooth was on development. The endodontist that tried to make these treatments look for the buccal canal. They try to get to the apex in the X-ray, so it's tried to go farther and farther and farther. Of course, if we analyze the X-rays at the apex could be here, but we know that it's not here, so he make a perforation. So we have to explain to the patient, we have to open the tooth, we have to clean everything, we have to try to seal the perforation that we have in the buccal part, we have to reconduct the palatal canal, we have to clean the palatal canal. So it's very probably that we are not able to do that. If you are not able to do that, we have to solve the treatment with an surgical treatment. Okay, so here we can see the big difference that we have. It's not absolutely the same. So nowadays we can say that it's a must to have a cone beam when we want to do surgical treatments. In general, if you want to put implants, if you want to make any kind of surgical treatments. And here we can see that the cone beam is always right. We have this secondary canal, okay, in that part. So we have to prepare the secondary canal. We also have a small fracture, apical coronal fracture. In that case, we know that the rate of success is not the best, but in this case, we clean this fracture until we were not able to see the line of the fracture. There was not bone defect in the buccal part, so we can clean it. We can seal it with the new materials, with the new bioceramics. The result is really, really good. And we were able to close and take out all the bacteria. That is the goal that we have. And of course, after 1 year, we have a really good regeneration of the apical part. So it's true that nowadays I think that we could do better because we have a small recession of the bone here, and we have a small concavity. And I think that if I do it now, I could make a slightly bigger regeneration, trying to think that if this patient has a problem in the future, not now, 5 years, 10 years, 20 years, because she was very young at that moment. Okay, so we could have a better situation to put an implant in the future. Okay, another variation, anatomical variation that we have is the calcified canals, and mostly if we have a PCO, a pulp canal obliteration. This is a patient that has a trauma, he has a pulp canal obliteration. We have to give it very clear. The calcification of the canal is not hepatosis, it's not a biological problem. This case, for example, the mistake was made by the dentist. The tooth was brown or was like orange, because we know that this calcification tissue is not exactly the same color as the tooth, so it changed the color. So the dentist decided that he wants to do an access and he wants to do the treatment for internal blanching, thinking that if you want to arrive to that canal that it doesn't exist, and if the cone beam is it's the cone beam that we have to send for endo, so a cone beam that is less than 100 microns and with a small field of view, and you are not able to see the canal, you do not have any kinds of justification to try to open that tooth. The calcification in the canal is not hepatosis. If you don't have an apical periodontitis, it doesn't have any sense to try to open the tooth. Send to anyone that makes aesthetic in the proper way, trying to solve it with a veneer, with a composite, with any kind of material. Do not open the tooth, because if you open the tooth, after 3 years, the patient came like that. He's the brother of one very good orthodontist here in my city, and he wants to say, okay, let's try to keep it like that to see if it doesn't appear any lesion. It was not like that after 3 years, and now we have the problem, and we create the problem. We really create the problem. Okay, so now we have to do something. And in our experience, when we are not able to see the canals, our procedure is not by the orthograde way. We will do it in the apical surgical procedure, closing here, trying to reduce the option to having the failure of the bacteria and making the retrograde preparation. Okay, so when we do the surgical treatments, in that case, we cut the 3 millimeters that we have to cut. We know that we have to cut the 3 millimeters because we have the 92% of the lateral canals, and we have the 95% of the apical deltas. Okay, so we need to cut 3 millimeters. And after cutting these 3 millimeters, we can see that there is a full calcified structure. So if we want to arrive, no, because sometimes we think, no, the cone beam is not giving to you the right view. I'm very skillful. I can get the canal, I can open it, and I will be able to finish the calcification, or I will make it with a guide. We did a couple of studies with guides, and to make nowadays guides is excellent for that. But we have to see the canal in the cone beam. If we are not able to see the canal in the cone beam, we have to think that the idea is we don't have a canal. If we don't have a canal, we have to make this canal. We have to destroy the tooth trying to get to this apical part. And what you will have in the future, you will have a very destructive teeth, and with this very destructive teeth, you will need to also make the apical surgical treatments. So the idea is trying to reduce this. This is another case. We have a canine, it's 27 millimeters canine. We have an apical lesion, we have a lateral lesion. In this case, the endodontist, he's a really good endodontist, and he was his brother, his sister, sorry. And he tried to open, he mixed X-ray, he make the combine, he used a microscope, and in a moment he decided to stop because he was not able to see anything inside the canal. So there is not reminiscence of the canal. We cannot see the difference of the colors. We cannot see all the details that we use to explain for ourselves and for the students. Says you had to be guided by all the details that we know. So the idea was we made they made the combine and they said, okay, there is not canal. So how we'll manage it? Again, we will manage it by the surgical procedure. Okay, and again, after cutting these 3 millimeters of this 27 millimeters longer tooth, we still having 24 millimeters of calcified canal. And if you want to try to open that in a 12, 15, 14, 16, 17 millimeters, the variation of your angle is really important. But when you have it 27, 28 millimeters, if you vary the angle of insertion of your ultrasonic unit or of your Mons burn, you will destroy absolutely that tooth. So you will have a very big canal and you will have a very, very small amount of remanent structure. And the problem will be that the tooth will get broke in 5 years if you are not able to try to reduce this structure of the destruction of the structure. Okay, so again, we did the canal. Of course, we have to perforate this dentine because there is not a space between the canal and the walls of the walls of the root. Okay, so we do also in the lateral position. We do the apical surgical treatments. We clean here and we seal exactly like if it was an apical preparation. It's a lateral preparation. Oops, sorry, and we can do perfectly, o sea, disinfection, lateral preparation, obturation of the canal, and we will make the regeneration of the bone, lateral bone, and we will have a right success. In these cases, we do not put any kind of membrane. We shoot with 7 zeros. That is something that I love. How to manage the tissue in apical surgical, I think, is one of the most important thing, and it's something that we can work a lot on this because we're still having some old concepts. We have to learn a lot from the periodontists in that way. Okay, we can see after 3 days and we can see after 2 years. And if we manage the tissues in the proper way, we will not have any kinds of alteration in the soft tissue. Okay, so, and of course, we will see how we have a healing in the apical side, how we have a healing in the lateral sides. I am absolutely sure that here we're still having some bacteria, but we have to leave the bacteria inside the canal. Maybe in this case, we could have failure in the future. We have some filtration in the apical and the lateral part, but if we're still going with our burns in that way, it's absolutely sure that we will destroy this very, very popular nowadays concept that is a pericentral dentine, and if we destroy the pericentral dentine, it doesn't care what you do. You will have a fracture, and if you have a fracture, the tooth will be destroyed. Okay. Another of the anatomical variation that we have in so many cases, and we have a lateral canal. In this case, we have the lateral lesion. Of course, we can think in trying to retreat it in the regular way. The patient do not wants to have another retreatment. He prefers to do a surgical treatment because he don't want to destroy the field. The field was not okay, but it was the idea. And in our hands, sometimes we prefer to do in the lateral preparation with an apical surgical treatment. Okay, in that case, we can see also in the combine. And when we make the flap, when we do a small osteotomy, we start to make the apical inspection or the lateral inspection. In that case, we can see that how big is this lateral canal. It's really big. So again, we prepare, we clean. If you want to disinfect the canal, it could be perfect. You make the same procedure that we do in the apical part of the tooth. We seal it perfectly, and after sealing it perfectly, in that case, the regeneration is not so important because we have all the walls, but if you want to regenerate, you can regenerate. Here, you will see like how you have success when you have a properly obturation. In that kind of cases, we always do a retro preparation and a large retro obturation in the apical part 2, but we will have a really good success. This is a strange case because we have a super big lateral canal, and we can also prepare with a burr. So imagine the size. So how we manage it? Exactly in the same way. We clean, we prepare, we disinfect. If you want to disinfect with hypochlorite and you are able to do not affect the bone, it could be okay. If you want to disinfect with a laser, with any one of the systems that we have to make disinfection, the concept is absolutely the same. You have to clean as much as you are able to, and after, of course, you have to seal perfectly to try to reduce the leakage of the bacteria that we can have. If you reduce the amount of bacteria, we can see that after 3 years, we have a really, really good success because we have a good healing. There is other cases that it has to be related also with the anatomy of the tooth, and it has to be related with the structures that is affected, okay? In that kind of cases, this is a difficult case, okay, but when we see the X-ray, we can see the combi, we can see that we have a double curvature, we have a very, very narrow canal, we are not able to see, and we can see that also we have a really big relationship with the maxillary sinus. The membrane is already has some interaction between the maxillary sinus and the cyst. So here it's very important to understand where we are and how we can manage it. If you are not able to manage a possible perforation of the maxillary sinus, you are not able to do these kinds of cases. Of course, again, as when we start, we have to know surgery, we have to know periodontology, and we have to know endo for make these kinds of cases. So we open, we try to take the cyst as soft as with the more care that we were able to. We try to take all together. So instead of trying to take without making an osteotomy, we make a slightly osteotomy. With the piezo surgical units nowadays, the osteotomy do not produce a lot of pains to the patient. We start to take out the lesion, but we found that when we take out the lesion, we have some interactions with the maxillary sinus. And of course, you can see that here we have a big communication with the maxillary sinus, and all this tissue is granulated tissue. So we have to take it, clean it perfectly. It's not necessary to make a cut look. It's not necessary to clean all the membrane, okay? But you have to clean all the part of the membrane. You have to clean all the part of the bone that is affected, okay? And after that, of course, you can do it 2 different ways. You can cut. This is here, sorry. Here we can see perfectly that we can remain the mesial part of the membrane. It's not necessary to take all the membrane out, okay? And here we can see that we can perfectly make the apicectomy. In that kinds of case, before making the apicectomy, or in the moment that we were doing the apicectomy, we do not feel with gauze all the maxillary sinus. We feel the gauze, all the maxillary sinus, when we were doing the obturation, because we don't want to have anything inside the maxillary sinus. So softly, as the roots were all together, we make it very quiet with very small details. So we were able to pick up the roots without having the problems of making that the roots could go inside the maxillary sinus. And after we clean everything, we fill the maxillary sinus with gauze, and we can do the retro preparation and the retro obturation to try to reduce. Here we can see how we have it. In this kind of cases, for example, we use a 6mm ultrasonic tip. If we are able, in mostly of the cases, we prepare the canal not only 3mm. It's true that if we prepare 3mm plus the 3mm that we have already cut, we will have a real good situation for this apical canal, for these lateral canals, and for these other structures. But if we can prepare more, of course, we love to prepare more than 3mm. Okay, here we have the histology. We can see that there's some fragments of the maxillary xylem membrane, of course. Okay, and in that kind of cases, you need to know exactly what to do. So you have to put a membrane, you have to put some micro screws, you have to put this membrane, fix it to the vocal part, trying to reduce, and after that, try to make a regeneration. After 1 year, of course, the treatment is healed. Another indication that it's absolutely sure that you have to explain to the patient that after the regular treatment, it's really, really probably that you have to do an surgical treatment is when we have an apical resorption, like in this case. Okay, this is an inflammatory resorption. We can see that how the canal is preserved, where we see better in the photos, but we have a big apical periodontitis, and it's really, at least in my hands, it's absolutely possible to clean perfectly this apical part. So we will prepare until the canal starts to get resorbed, and after that we will do an apical surgical treatment in this other part. So you will see it's also happened in the lateral incisor. It's not the same kind of resorptions, but it also have a resorption and it also have a necrosis. So we will do in both cases the root canal treatment, and after that we will do the apical surgical treatment. Okay, so here we can see that here we're still having some remaining part of the canal, of the on the cortical of the canal, but here we will not be able in any cases to clean and to reduce the bacteria to try to make that treatment works properly. Okay, we do the treatment with 1 year, and after 1 year, of course, in this case, we did the regeneration with a genografting material, so it has this strange, we can say, but here we have a lot of structure. We know that we will lose part of this material, but we will have a straight line, no concavities, to making that if we have any problems in the future, we were not able to make the inclination of our support in the proper way. Okay, so there is other anatomical variation, that this anatomical variation, we will see that we have a delta, bifurcation in the apical part. We have 1 canal, 2 canals. I tried to do the retreatment, and when I did the retreatment, I think that something was not working. And when something is not working, we can see that from the central gutta percha to one of the sides is 1 millimeter, and from the central gutta percha to the other side is 3 millimeters. So what we have to think is we have an anatomical variation, and in my hands, it's absolutely impossible to try to clean it in this other side. So what we do is to make the flap, make the osteotomy, start the retreatment to clean the lesion, of course. We always send all this material to the biopsy. In 100% of the cases, it's true that in more than 300 biopsies, we never had nothing that it was not, well, we have a couple of keratocysts, but in most of the cases, it's a granuloma or a cyst. And here we can see perfectly 1 canal, 2 canals, and a space, okay? So if you prepare these 3 canals, and of course, it's absolutely mandatory to clean the isthmus that we have in the middle between the canals. If you are not able to clean this isthmus, this case will not work in any case, okay? Because we have to clean the canal. We are not going to prepare the isthmus in the 3 millimeters. We're going to prepare the canals in 3 millimeters, and after we're going to clean the isthmus only, not more than 2 millimeters, because we have the concavity. And if you prepare 3 millimeters, you will be able to block the root. And after that, you have to do the obturation. When we do the obturation and we clean the canal properly, what it will happen, okay, again, 1 canal, 2 canals, 3 canals, a very large isthmus, and when we stain that with methylene blue, we know that if the methylene blue is there, it's because we have organic tissue. And if we have organic tissue, we will have bacteria for sure. 1, 2, 3, we clean the middle. 1, 2, 3, we clean the middle, and what happens is works. It works means we have a really good recovery of the bone. We don't have any kind of apical periodontitis, and we have a really good. We do any kind of X-rays in our treatments until we make the cone bead in 1 year. If the patient doesn't have any kinds of pathology, any kinds of, again, percussion, palpation, we do the review in 6 months, and in these 6 months we see If it's nothing happen, we will wait and we do one convene in 1 year and the second convene in 5 years if everything goes in the right way. Okay. Another indication that we think that is very interesting to use apical surgery is when we have a broken instrument. In that kind of cases, we can see that the straight line is really good. We will see that if we are, of course, we don't need to be Yoshi Terauchi to take out these files. It's going to be very easy because it's a straight. You open here, you go here, but when you have the convene, you see it's not the same. It's not the same because the angle of the palatal broken file, it's okay, but the buccal one, it's really inclinated. You have to destroy a lot of structure of the pericervical dentin, but you have to break a lot of structure here. I don't know exactly why this resorption is there. There is it's a resorption, but in my hands, it's absolutely impossible to try to take these files out. And in my opinion, it's much more conservative trying to take these files out with apical surgical treatments. Of course, the files was there, and in that case, we cut the root very, very high, but we can see that if we clean again, here you have to be very sure that you don't have a periodontal problem, because if you have a periodontal problem or a periodontal pocket, you will have problems, but the regeneration is really good, and we can see that how we can manage it. Again, we have to think in 3 dimensions always. We can see this file. In this file, again, it's a proper anatomy. It's a good position. We will be able to take this file out. We have to prepare. We have to open, enlarge the canal, sometimes a lot. We have to clean everything, but we have a straight line. But when we have the convene, there is not a straight line at all. The line of extraction of this file is this one. So here we have to destroy a lot of structure. We will have to destroy a lot of structure here too, and the prognosis of these two will be really, really bad. So what we can do, we can open, we can clean it. It's outside of the canal. So you can see that it's in 2 minutes, 3 minutes, 4 minutes. We can take the file out, and now the file will not be the problem. Okay, we do the regular treatment with apicectomy, the retroprep, the retroobturation, and we can seal it to try to see that everything works in the perfect way. Again, this curvature that we have here is because the perfect adaptation of the bone to the apical part is because we use a bioceramic. This curvature here is because we use regeneration in that kinds of cases. Okay. When we have a perforation, it depends on where the perforation is. We could think in trying to solve it in the orthograde way or in the retro way. When we solve it with the orthograde way and we have the lesion under the bone, it's okay. But when we have the lesion over the bone, in my hands, it's quite difficult. So of course, what we do is we see this is a problem of the access. There was some material here. Maybe we can seal it perfectly, or not perfectly, but quite good. But the problem is we have to take out of the materials, and this is very, very difficult. So we prefer to open, to clean, to make the cleaning, and you will never have bone again. You will need a large cell attachment. So we have to try to polish it to make any kind of periodontal treatments. But we will know that here we will not have bone. But if we manage it in the right way, for example, in this case, I have in the longer presentation that we show how we do a soft tissue grafting, how we take the connective tissue from the palatal, how we put it there, and how we enlarge this connective tissue, and how we keep perfectly the reposition. We make a coronal reposition. We live in the perfect state epithelium, and how this tooth in a long time will be a real good success. And that doesn't mean that the tooth is survival in the mouth. That means that the tooth will be in the mouth with aesthetical conditions. Okay. Another indication that we have is when we have an overextending material. It's really, really difficult, and we have to know that in some cases we will reduce the destruction of the tooth. It will go diagonally on surgical treatments without making any kinds of retreatment previously. Here we can see this resorption on the apical part. We can see that we have not only material in the lesion, that also we have inside the maxillar sinus. So we know that we have to take out all of this material, and we know that it will not be very easy. We have a maxillar sinus inflammatory membrane. Okay, so again, what we have to do is to open, to make the osteotomy, to take everything out, see how many materials do we have inside, how many tissue do we have inside, and after cleaning everything, of course, we do the episectomy, retroprep, retroobturation, and the success of the case. Other cases are the cases that there is a full mouth rehabilitation as that, or crowns that are very new, or very, very important aesthetical crowns, and the dentist says, you are not able to touch my crown, because if this crown gets broken, we will have a real big problem. So the idea is we feel much more comfortable making an apical surgical treatment, okay? Of course, in that kinds of cases, you have to select perfectly which will be the design of your incision, what will be the design of your flap, because it could be an absolutely disaster if you have some problems. But in that kinds of cases, it's a real good alternative to try to reduce these options of having a broken porcelain. Okay, in that case, we could see how we do. Another prosthodontic reason is we have an intra-radicular anchorage when we have a post, and mostly in the cases that we have a very long post, and we know that we can take the crown out, we can take the obturation out, we can take the post out, but we will be able to have a fracture. And in that kinds of cases that we have a through-and-through lesion, and we know that it will be easier if we can regenerate, the surgical procedure is really indicated. We know that if we have a surgical procedure with a through-and-through lesion, we have to regenerate in 100% of the cases. I love to regenerate, but I know that it's very controversial. I know that there is a lot of people that prefer to do not regenerate in most of the cases, but when we have a through-and-through lesion, we have to put a membrane, we have to use some materials, and we have to put a membrane again. Okay, but in that kind of cases, the other problem that we have is when we cut the 3 millimeters, we have the post. So what we do, we don't do anything. We leave like that, and we don't put any kind of retro material. It's not like that. We have, as in the same way that we do for take out the file, we touch around, we clean around the post, and we get 3 millimeters all around the post. And here at the top of the post, of course, you will have 1 or 2 millimeters, no more than that, and you make the retroobturation. It's very important if you have a post like that, do not touch the post a lot, because which is the way to take out the post is to use the ultrasonic unit. If you prepare with the ultrasonic unit to the coronal part, to the vocal part, it could be the reason, because after 6 months, the patient came with a crown in your hands, and of course, you will have a lot of problems with that. Okay, again, we did a mistake when we put the membrane in the palatal part, so you can see that how the palatal tissue that is really strong could have this entrance here in the regeneration material. But here in the vocal part, after 2 years, we can see that the healing is really good. Okay, we have always this excuse: our treatment is not working because we have an extraradicular biofilm. We know that we are not able to clean this extraradicular biofilm. Of course, the extraradicular biofilm exists, but if we analyze the studies, we can see that the amount of cases that we have an extraradicular biofilm, it's very low. We have to take it in account that the percentage of extraradicular biofilms in the general cases is more or less 6%, but when we have a sinus tract that has been in the mouth for the patient for more than 2 months, we have mostly a 40% of option to having a extraradicular biofilm. And the problems that we have that when we have this sinus tract is these bacteria are not endodontic bacteria, are peribacteria, are extremely difficult to take out. So we have to think it that way. So we have to explain to the patient that if we have an if we have a sinus tract for more than 2 months, the surgical procedure could be the definitely option. Okay. So, okay, again, depending on the size of the lesion, depending on this, we can analyze in the literature different variables that we have and how many cases we could have this extra radicular biofilm depending on certain parameters. Okay, so it's we know everyone about that. The important thing is that we have a calculus-like appearance biofilm. So we know that the calculus-like appearance biofilms is really, really difficult to be taken out. So this is a case, is from Felipe Restrepo from Colombia, and we could look at what is a real biofilm. This is not 2 or 3 bacteria that are around. It's exactly the same that we have in the dental plaque, in the periodontal tissues, and we have to make the retro preparation, make the apicectomy, the retro preparation, the tutorial. If it's not, this case will not work. Okay, we published an article with several cases several months ago with Dr. Alejandro Perron from Venezuela, but now he's living in Portugal, and we could see that these calculus-like biofilms that we have that were not able to be managed, any kind of management without the apical surgical treatments. Okay, we could see here when we have these 2 views, the lesion, and this lesion that is worse is because here we have the double walls effect. So we have a through and through lesion. Okay, and we can see here that if you clean it and we treat it in the regular way, trying to reduce the amount of bacteria, it will work. So another of the cases that we know that we will be most success if we treat it in the surgical way instead of the retreatment in the regular treatment, if when we had a previous failure surgical treatment. Why? Because we have to understand that the apical resorption that we will have will be like a disaster. In that cases, they have 2 obturation with amalgam in the tooth and another obturation of amalgam. This is absolutely clear that it was made by a surgical guy. Why? Because we can see that they have these small screws. So with the regeneration, it's perfect, but with the preparation, with the obturation of the apical part, is an absolutely disaster. Okay, here we can see, here we don't have nothing, but when we see which is the anatomy of that part, thinking, okay, maybe it's possible to do the access to clean it and trying to obturate it, we see inside. So I think that not only my hands, in the hands of mostly everyone, to seal that part of the canal in the proper way could be really, really, really difficult. So if we are able to make the access clean, of course, we have to cut, we have to try to stabilize this part, we have to take out the material that we have and seal it, we will be able to have a real good success. And again, here we don't have to think in the preparation of 2 millimeters, 3 millimeters. We have to prepare all the canals. We need 6 millimeter tips, we need 9 millimeter tips, we need to touch around the post, we need to clean around the post to try to seal most of the canal, because if it's not, it will not work. And this was other cases. I love these cases because it's mostly 20 years old cases. And this patient was referred because they think in taking out the 4 crowns, taking out the 4 posts, and taking out the 4 teeth. And I say, okay, we could try. No, but I already suffer, because if you make it surgical treatment in that way, it suffers surgical treatment. And I don't want to have another surgical treatment. And I explain, okay, let's try to do it another way with other concepts. Because here I think that they prepare the amalgam, he put 1, 2, and they doesn't have for the 3, for the 4th, so they forget about it, okay? And we don't have duration, so we will take out, we will clean it, we will make a 90 degrees angle of cutting, we will prepare everything, we will clean everything, and we will see if it's working. And of course, if we disinfect the canals in the proper way and if we treat, and this tooth was changing 3 years after, and she's with the teeth for more than 15 years, and the treatment is really, really good. For finish this presentation, I will show you cases that I like a lot, because it's not my case. It's a very interesting case. It's a root amputation. It's something that we can consider as like another kind of treatment in our specialty. This case was for making a root canal treatment when the Hipólito Fabras is an endodontist from Valencia. He made the root canal treatment. He found that the distal root was damaged. He could not manage it, so he prepared the canals, the distal canal and the palatal canal. He put amalgam. He make the amputation of the root. We can see here he polished perfectly the amalgam. Of course, here we could have some periodontal problems. Here we could have some pruvit. Here could have some problems with the furcation. Okay, but if we match it in the right way, we have the photos. We have the X-ray after. They make a crown. The fixation of the crown was really good. Of course, the patient has to have a very good hygiene. He had to pass the dental floss. He had to pass in 18 months, in 3 years, in 30 years. And I'm sorry about that, but I could show you I didn't have it here. So in 42 years, that is the last X-ray that we have. So this patient has been with the teeth for 42 years, and we will have it for more time because he's still being my patient. And now we could see that there is not any alternative, there is not any options to have any failure there. Okay. So as I explained to you, I will try to reduce the volume. As I explained to you, I will be the president of the national meeting in the last days of this month. We will have a lot of speakers. We had speakers from US, different program directors. We have speakers from different National Society of South America. We have speakers like Emmanuel, that is one of the guys that has more research, make more research in the world nowadays. We will have different topics that will be treated by different specialists. For example, in laser we will have three different points of view. In disinfection, we will have 3 different points of view. In surgical procedures, we will have 2 different points of view. So it will be a real pleasure that to have some of the Academy of Italian Endodontics participants or here in Alicante. So thank you very much. I think I've been more or less on time. Gianluca told me it was 1 hour, 1 hour and a half, or 1 hour and 15 minutes. So we will leave 20 minutes for questions. So I hope that everyone likes the presentation. I will stop to share the picture.
Thank you so much, Sebastian, for your kind presentation and for your beautiful material. Really beautiful material. Thank you so much for sharing it. And of course, I invite all the members of the Italian Academy to reach Alicante for this beautiful meeting. We almost every time have some members from the Italian Academy going to the Spanish Academy and the opposite. A lot of you from Spain, you come in Italy. So I hope that this year will be the same there in Alicante under your presidency of the Congress, because you deserve it. So thank you very much. Thank you very much, Sebastian.
I was speaking with Nicola that usually we have the holidays for the kids this week. Yeah. So we used to go to ski, but this year we will go to ski to the north of Italy. So we can go to Bologna, we can stay there, and after we can go because if it's not, that you know that the family who wants to kill us several times when we start to fly, and this is the weekend the week of. Yeah, and I was looking for a couple of places in the north of Italy, so it will be a good alternative.
Let me know if you need any suggestion, because it's a good match. It's a good way to do some holidays and then come to Bologna to enjoy our meeting and our party. So Seb, we have a couple of questions already.
Yep.
Doctor, okay, great. Thank you, Fabio. Do you have any decision tree on how to proceed with soft tissue incision design?
I don't have a decision tree. I think this is the question is really interesting. I have my decision tree in my mind. It's true that it could be very interesting to have an article about that. And I think that is the point that we are more far from being good in that way. So it's where we had to work with the periodontist. This weekend in Peru, Nicola was speaking with the periodontist hand by hand. So I think that we have to learn from them, because from the surgicals we know how to make the regeneration, we know how to treat the bone, we know that we have to use a piezosurgical because we will have a better healing. We know that the size of the bone osteotomy has to be in that way, but we're still having some problems with the soft tissue management, because we can make a flap and in our mind is trying to put it again in the same way. Perfect. That's because you found it in that way and you will leave it that way. But nowadays, maybe it's not the best option. If you have a recession and you can do in one intervention, you can solve to the patient two things, it's perfect. If you think that the patient will have any periodontal problem in the future, why you are not trying to solve it before it happened? And I think it's the place we were speaking about that in Peru. It's true that the line of surgery has improved a lot, and mostly of these improvements has been made by the UPenn guys or the UPenn University, and they are really good in the endodontic management. They are really good in the hard tissue management, but they are not really very worried about the soft tissue. And now I think it's the moment that we have to try to focus in these soft tissues. And when we start to learn about soft tissue, we have to, as a endodontist, you have to know 4 or 5 variables that we can have, and in that way you have to decide where exactly is the line of the bone, which is the free gingival, which is the attachment, which is the mucosa, which is the line of the mucosa. If you have these 3 or 6 of these 5 points, and you have a very, very good periodontal proof, it's very, very difficult to fail in the design. With these 2 or 3 parameters, you can say, okay, and it's true that now we have 2 or 3 kinds of insertion: intracircular, submarginal, and now we are changing. And I love this part because it's something that is not very popular. It's the Vista design. It's the vertical incision. And again, in one of the meetings that we had in the National Society, we did it in Baqueira. It's a ski resort, and after skiing, we go and with some beers. There was someone from Italy and said, "This is the first time that I see the speaker speaking with a gin tonic in the hands." So this is these kinds of meetings, and there were a couple of periodontists that explained to us that they are making full mouth regeneration, making 2 vertical incisions. So if it's that guy can put 2 micro screws, 1 titanium membrane in the second molar, making bilateral a vertical incision, we have to be able to. And we have been working in that, and we think that it's something that it could improve. It changed absolutely the way that we see, because we want to make the flap, put it again in the same side. But we have to understand that all the studies from mostly of the Italian groups, periodontist groups, say that if you make the flap, you will lose bone in 100% of the cases, between 0.28 and 0.35, but you will lose bone. And if you lose bone, you will lose gum, you will expose some part of the tissue that you are. So in that way, I think there is a lot to do. So it's nowadays, if I had one to try to take decisions, I'm mostly sure that in 1 year, 1 year and a half, 2 years, we will change that, because we are doing some horizontal incisions in short teeth, making not the vertical incisions, because we don't like vertical incision for the tension that is produced. The periodontists know that the tension is the enemy. So if you cannot control the tension, you have to be very worried. The guys that make hard tissue degeneration know that the pressure of the tissue is the enemy, and if you don't have vascular a good vascular healing, it's also. So we have to take all this information and we have to put it in our fields. And the problem is that they don't know endo, and if you don't know endo, you will never will be success. Okay. So I think it's the field that will change a lot in the future, and we will have to work a lot with the periodontists to try to help us to make the things better.
Sebastian, I want to thank you very much for mentioning this aspect, because you probably know, but our academy is a multidisciplinary academy. We take very much attention on the relationship with the other disciplines. You mentioned Nick there in Peru. He was there with one of the president-elect of the Italian Society of Periodontology, Raffaele Lello Cavalcanti. So we really love to make endodontics in relationship with the other disciplines, because it's very important. You mentioned it. If you can solve a perio problem together with the endo problem in just one intervention, why not? But you have to know you have to know the possibilities and to be prepared to do it, or to do it together with another specialist to solve the problem to the patient. So this vision is very important.
And sometimes it's not necessary to be a super specialist in this other field, because it's true that you will not know how to, but to make a soft tissue grafting, you need the microscope and make it 3 times, because it's quite easy. And in the moment, if you have any skills in the surgical procedures, and you know how to make a small cut in the palatal, suture it, and put it in the place that you are making the surgery, suture it again and close it, you will have a real good success. And that is not going in the same line like we are thinking in the apical surgical procedures nowadays, because we were not worried about it. It's not our problem. Yes, of course it's our problem. And if you want to stabilize the tissue and you don't want to have any periodontal problem in the future, you are going to make the problem, because you are going to flap, to rise a flap. Because if you don't rise the flap, it's okay. But we know that when we rise the flap, 2 or 3 weeks ago, there was the AIO, Association of European Association of Osseointegration, and the most important conclusion was no one has to take out a tooth if we want to put an immediate implant placement without making soft tissue grafting. The studies in 5 years shows in 100% of the cases that you will have periodontal problems in this implant, or periimplantitis problem in this implant. So in 100% of the cases, even if you think that you have a very thick periodontium, or if you think that the cortical bone is okay, they say you always have to put some grafting soft materials in the vocal part. That changed a lot of the concepts. We are going to raise the flap, and we need to open the flap, because we have to arrive to our pathology. So that is really, really important. We will lose both in 100% of the cases. No, we are going to do a submarginal incision. You will have a recession. If you make an intracircular, you will have between 1.2 and 1.5, depending on the status of Peter Verbal. But if you make a submarginal, the contraction that you will have for this reduction in the vascular procedure, because the vascular procedure is vertical, and if you cut it, you will reduce. You will have the collateral and you will have the palatal, of course, but it's not the same. You will lose between 0.06 and 0.09. So you will lose attachment.
In any case.
In any case. So we have to know that if we can try to make something to reduce this option, you will reduce a lot of problems. If the patient have veneers or have crowns, you will produce a problem like that. So
and this is of particular importance when you have such kind of prosthetic reconstruction, right?
And you know that now the people is very, very focused on the aesthetics. It's very important. Okay, I keep my tooth in my mouth, but I don't care about it. I only care that I can see a small line of my super expensive ear that this was not before. Yeah. And it's your problem. It's our problem in that way. So how we can manage it? Thinking in other way. And it's true that the periodontologist has a lot of knowledge about that. So we are not going to be periodontologists. That's absolutely true. But it's not necessary. At least till I've been working with periodontologists several years. We we need the 20% of their information to change our rate of success and to do the better, much precise that we can do. And again, it's not difficult. If I put always the example of the pediatric dentistry, if you want to learn about the behaviors of the control of the behaviors of the kid, it's extremely difficult. It's super difficult. It's not something to be patient. Now it's knowledge. It's information, how to treat kids, how to. So in my opinion, it's better to teach to the pediatric dentist how to treat tooth, how to open, clean, and they can do the work. In my opinion, here it's easier that we understand the periodontal concepts and the surgical process, that the odontologist or the oral surgicals understand what we are doing. So we have to do the people that make the treatments, but we need to know how they could match in the real, we could say, upgraded level, because we have been forgetting about this soft tissue. Again, I have a lot of fights with a lot of real good endodontists about when you have, it's not necessary to regenerate. If your bone is, the line of the bone is more than the buccal plate and blah, 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 it's not necessary. It's true. It's true you analyze in the 2 dimension, but you analyze in the 3 dimension and you don't want to lose any part of the bone, we have better results if you do regeneration. It's more difficult, maybe more expensive for the patient, but the result is better. And what we try to do is to get a better result for our patients, and that's the idea.
It's very nice for us to see your how you are open-minded and open to cooperate with the other disciplines. It's very interesting. Our common friend Emilio Serena is writing a comment to thank you for your excellent webinar. And there are another couple of questions.
Emilio will be the honorary president of the meeting.
Oh, nice! I didn't know, but Emilio is a very good friend. Why the apicoectomy cut line was changed from bevel, Sebastian?
Which the apicoectomy cut line was changed from bevel? What?
I think they are meaning that now we are doing an almost 0 degree cut line.
It has to be, yeah, perfect. It has to be 0 degrees because we have to. This is, for example, extremely. I teach in a couple of universities in the surgical departments about. We have to know about endo because our problem is the microcanals that we have inside the canals and in the lateral canals and in the dental tubules. And that's the idea. That's the most important part. When we have a 45 degrees, we will expose a lot of dental tubules. If we expose a lot of dental tubules and these dental tubules have bacteria, we will have a failure. If we cut in a 0 degrees, okay, the idea is not more than 10 degrees because sometimes it's very difficult to cut in this 0 degrees. You will have always cementum around. So you could still having some bacteria in this dental tubules, but it will be much more difficult to the bacteria to go out from the dental tubules to the periodontum by the cementum. If you cut it in 45 degrees or more than 45 degrees, you will have a super, you will produce a highway that the bacteria can go through this space. Okay, so it's true that it's more difficult, but it was more difficult before when we had the handpiece or the micro handpiece to make the retroprep. Now that we have the ultrasonic tips, it's only something about the way. As I explained, I use a lot of times the 6 millimeters tip. And the people say, how you can get it? It's something about the skills. I'm really not very skillful. If I'm not very skillful, if I do that, everyone can do it. So it's not necessary to make a 10 millimeters space or crypt for the bone. With 5 millimeters, with 4 millimeters, you can change the angulation, put it inside, and make a retroprep of 6 millimeters and trying to reduce the amount of bacteria. And of course, in 0 degrees, you will not expose these dental tubules. That is the reason because we want to try to reduce the bacteria.
And we have to say that this is possible thanks to the quality of the new devices, materials, the magnifications of the microscope, the ultrasonic tips, the piezo, all the devices that we have helps us to be more and more conservative, to do a micro endodontic surgery with these modern principles.
Absolutely. The idea of I think this was in the first moment was extremely good, but now we may be a little stopped by that concept. The father of the microsurgical concept is Sigmund King and all the Pennsylvania group. So we try to make the regular or the old way or the classic surgical treatments and the microsurgical, saying that is the new way. Maybe it could be better to call it in the new way, because when we think about microsurgical, it's very important to have a microscope. It's not only important to have a microscope. Have a microscope is important, but it's much more important to have the concepts. And this is why we can say that nowadays the rate of success of the treatment is extremely high, because we adapt the concepts, and the concept is no more 45 degrees, 0 degrees, a good retro preparation with an ultrasonic tips, a really, really good inspection. This is much more important than most of the things. To have a really good inspection and be able to analyze if you have a lateral canal or if you have an oval canal. Of course, we do obturation materials. All these things are the things that we make a unit with the micro, but it's not necessarily micro. It's the most important is the changes of the concepts. And I think the next step of the changing of the concepts is to adapt it to the perio and regeneration ways. When we have it, our rate of success will be even better. And we know that the rate of success of the apical surgical treatments is really, really high. Really, really high.
Thank you, Sebastian. There is another question that I don't know if we have an answer for it, but is it necessary Carnoy solution that for people that doesn't know, this is a mixture that has been historically used as a fixative for the histology? I don't know if you have mentioned it.
No. I use only the formol. I put the lesion in formol and I send to the pathology. Okay. And I only had.
This is just for the analysis afterwards.
Exactly. I am not an expert in histology. I only analyze. I love to have the cuts because I'm always trying to learn, but I'm really not an expert, and I have the result that what the I of course we know that usually we could have some mistakes, because if they cut it and we only have 2 or 3 cuts, we could say that it's a cyst and it's not a cyst, or it's a granuloma, it's not a granuloma. We try to make that the histologist make at least 20 cuts and different ways to analyze if we have membrane, if we don't have membrane. But I really am an expert in histology. I think that it's a must to do the histology of all the lesions that we take. We know that mostly with my friend Juan Saavedra, he will be here too. We have more or less, he had like 700 cases with histology. I have mostly 350. So we are trying to do a research about, because we have the cone beam and we have the histology, but we are not really an expert in the histology in itself. Yeah. But it's necessary because it's published. There are some cases that is a metastasis of a carcinoma. There is another case published 2 years ago that was a metastasis of a skin lesion. So we could, one was an hepatic carcinoma, another was a skin carcinoma. So we could have, we really hope that in our professional life we never have to a metastasis like that, but it could be an alternative, could be an option, and we need to do all the biopsies in that cases. So as I say, I am not an expert in the procedure. I always make that the histology make it, and we have the result.
Okay. Fabio, do you have any question for Sebastian? Do you want to add something?
Just one question. If you have any tips or tricks about blooding control.
Yeah, the blooding control is again, for me, When I say that, the people say that I'm crazy. The most important part is the inspection of the apical part. And if you have blood, you are not able to do the inspection of the apical part. So you are zero. So you need to stop to work and make another way. We have a lot of materials. We know that everything that we put to try to reduce the bleeding of the crypt when the crypt is bleeding, it will make an interaction with the healing and will an interaction with the bone, mostly with the angiogenesis. And if you reduce the angiogenesis, there is no blood, there is no blood, there is no life. Okay, so in my hands, the most important step is the anesthesia. We need an anesthesia. In US, they have anesthesia that is 130,000. That is crazy of adrenaline. Here we have a 150,000 of adrenaline. Usually we use articaine 100,000 or articaine 200,000. So here in Spain we have a lidocaine, not articaine. Okay, that is one part for 50,000. So if you have one for 50,000, you can block the beta receptors and you can reduce a lot. If you do it in the proper way, you don't have to put anything. In 90% of the cases, I don't have to put anything. What is the most important part? You have to put it in the attachment gingiva, not in the mucosa, not in the free gingiva, in the attachment and wait 15 minutes. If you don't wait these 15 minutes, the beta receptor will produce the contrary effect. It will start to bleed more. It will produce more bleeding than the normal way. Put anesthesia, you will see in the same moment that the gum start to be white, super white, okay? But you have to make the proof, 5 millimeters of fluid, 4 millimeters, 3 millimeters. You have to move the tissue. Here you have the line of the mucosa, and you have to put exactly in the middle. You put 1 drop, 2 drops, 3 drops, you go on the other side. This is not for the anesthesia. After you can put anesthesia in the vocal part if you want. This is not for the pain of the patient. This is only for the anesthesia. You put it, leave it like that and go to take a coffee. Or go to make whatever. 15 minutes. If you don't wait 15 minutes, it's a big problem. Okay? After that, you start to work of course, you have to take all the granuloma tissue. This is the most the thing that produces more bleeding. You take everything and it's still bleeding. We only use adrenaline, pure adrenaline. You buy in the pharmacy. You put 1 gas. We make that the assisted cut gases in very, very small pieces. We take 1. We put it with adrenaline. We package it. And we start to put more and more and more until it's full of gases. The first one is the only one that we put with adrenaline. That this is the technique that they are using in UPenn that I learned from them, and it's really good. You put 1, and after you put 6, 7, 8, 9, you have to count it because it seems as a stupid thing. But if you don't count it, when the lesion is big, after that you start to look and you say, okay, we put 9 or we put 10 and we take out 9. What is the other one? And you start to look, and you see that it's hidden behind the roots or whatever. And if you put it, and you leave for 5 minutes. If you take out, never take the last one. You have to take, you put 10 or 5, take the first 4. The last one you leave like that, because sometimes it gets like added to the tissue, and when you take it out, it's broke this addition. So you leave it like that. And it's very, very, very probably that you will not have any problems with it. With that, we don't use any kind of other kinds of solutions because it's make an alteration. In some cases now we are trying with the lasers. The lasers, I think we will use a lot the lasers in our specialty in the future mostly with the high powerful lasers, with the erbium jack or erbium chrome lasers start to be slightly cheaper. Okay. And it's true that when you have some vessels that is really bleeding, you can cut it, you can reduce the bleeding with a laser. But in 80% of the cases, it's only the anesthesia. And in the 20% more, it's 19% of the cases you can control only with 1 drop of adrenaline and the pressure with the gauze.
Thank you, Sebastian.
Very interesting tips and tricks, Sebastian. Thank you so much. Fabio,
No,
if you
that's a
don't have any
clinician
other
part.
curiosity or any other question for Seb, I think we can leave him to go to bed after.
Yeah, I think he
being back.
deserve a rest.
Exactly.
No, I have to.
being
I have my kid.
directly
I
by
had to
the
speak
room.
with my kid for a while, and after I don't know exactly when I leave the hotel in Lima. It was like 40 hours ago, and I will try to.
Really, we appreciate very much your kindness, and we don't want to steal more time to your family. Seb, we will wait
Really,
for you.
thank you.
We will wait for
the
you
invitation.
in Bologna, and hopefully we will see in Alicante.
You know that from when we was at the university, we have a lot of relationship with the academia. Now the academia, and it was really good, but now it's good and big because you are making that the academia has a bigger name, has a super, and of course I was looking for the amount of courses that you are doing and the way that you are doing. It's really interesting. We can learn a lot about that. And it's a real pleasure. You know that I love Italy, and more with good friends.
Thank you so much, Sebastian, for your friendship. I thank you so much. Thank you, Fabio. Grazie mille per l'aiuto. Diamo appuntamento a tutti per il prossimo webinar in un paio di settimane circa, il 20 ottobre. Buonanotte a tutti.
Buonanotte.
Ciao a tutti.